Thank you so much, KK sir, and good morning all the panelists and good morning, Cyrus. It was like I was just remembering almost 10 years before when I did CM in my own hospital, PRASAD Netralaya. KK sir, along with the madam, came to my hospital and gave a fantastic talk quite long back, 10 years before, and blessed us and went. Once again, I thank KK sir for this opportunity. So today I'll be talking about prevention is better than cure for subluxation. So most of the speaker will be talking about the what and all the methods to prevent subluxation or treat subluxation, but I'll be talking only about the prevention. I don't have any financial disclosure. So subluxated lens possesses one of the gravest risk of complication during the surgery. Preventing it from occurring is most important aspect to focus. Vitrectomy and fixated IOLs always results in some degree of irreversible vision loss. So it's very important. Caution and preventive measures will minimize the risk of better outcomes. So indication for surgery in subluxation, deterioration of the vision, lenticular opacity with poor visualization, lens-induced glaucoma, uveitis, or anisometropy or refractive error not unable to help with the spectacle correction, and even impending dislocation of the lens. So these are the complications you can expect after subluxation, that is glaucoma. It can happen glaucoma, uveitis, corneal decompensation, and retinal detachment. So coming to the preoperative evaluation is very important. Evaluate the lens position and identify the phacogenesis or the cataract grade. You need to know the exact degree of the zonular loss, whether the presence of vitreous in the antechamber or not, you need to find out. If an inferior subluxation often indicates 360 degree of zonular insufficiency, always combined with the effect of gravity. So always you need to know about how much is the visual prognosis. So patient counseling very important. But I always even do patient with the subluxation about the genetic counseling. If they are, I suspect a morphine, always I send them to the physician. So always you have to think in your mind there is a possibility need of secondary or fixated intraocular lens. This is the one video I'm just showing you during the table. See, this is not a case exactly subluxated before, but what I wanted to show in this particular case, see someone like a grade 4 cadet, they picked the chopper, what they have picked up is also, I feel that it's not a sharp chopper or a, the chopper, it is a regular chopper. He was finding difficulty because of excess manipulation in this case. I think lens has become, zonils are become loose and lens has become subluxated. So whenever keep an eye on when you're operating a hard cataract, pseudo exfoliation, small pupil, hyperopic patient because with the crowded eye, high lens thickness, and especially older patient. See, there are few of the videos I took from my friend Deepak Megur. So this is about the intraoperative consideration when you're doing high risk cases. If the patient has got a small eye, do a lateral canthotomy. If you think that there is a high posterior pressure, give IV mannitol. I prefer to do a larger rexis, how Deepak is doing in this case, with the help of a forceps. And always limit your hydro procedure. This is very important. Do not rotate the nucleus excessively because it will even make the subluxation worse. I always prefer to do a vertical chop, especially when I'm operating hard cataract. And the guarded lateral separation of the nucleus is very important. This is the management protocol. If it is minimum, some people even give the spectacle correction. If it is marked, I think try a spectacle correction. People used to do something called optical iridectomy before. Even people used to put myotics. And coming to the surgical removal, I think you can take through the limbal route with the help of hooks. I'll be coming in the later part of in my part, or you can go through the pars plana. So this is the main chart I want to show you. Subluxation less than 3 o'clock hours. Do a slow phaco PCIL. Not possible, go ahead with the pars plana lensectomy. Subluxation between 3 to 5 o'clock. Slow phaco with CTR, Sioni ring. Not possible, go ahead with the pars plana lensectomy. Put a iris clip lens. Subluxation between 5 to 7 o'clock. Do slow phaco. Reduce all the parameters. Sioni ring. Even you can add a help up with the CTR with the Ahmad segment. So see, these are the surgical tips. I think you need to do a good rexis 5 mm central as possible. Use high molecular weight viscoelastic. Always it has to be very important enough to overlap the optic edge after IOL placement, and also risk of development of capsule contraction, and use a direct chop because it allows to putting less stress of the zonules. These are the special instrument very much important when you are dealing with the subluxated lens. Especially when you are doing a poorly dilating eyes, you need to have all these hooks, Manugian rings readily available with you. You need to have CTRs and all segments with you. Important to have a vitrectomy unit with you, but do not forget to keep the high molecular weight viscoelastic. These are the device used. Once again, I am thankful to Deepak Megur who has given. After the Rexis also, you can put this iris hooks, but you have to be very much careful when you're putting these hooks. Make sure that you are not engaging the capsular axis. If you engage the capsular axis, you may have some trouble. So these are the indication, especially patient with a floppy iris or small pupil, you may have to put these kind of devices. Coming to the hydro and the phaco, I think I had already told, I'll not be. So this is multi-direction hydro is very important. CTR can be inserted initially if you are having the gap. When this thing, chop technique without sculpting is the most friendly technique, I always feel. So cortical removal is also very, very important. In presence of extreme laxity, removal can be done with the dry aspiration, or I prefer to do with the bimanual aspiration. Then this position also you can put the CTR. So IOL placement, you can put it either in the bag or you can put it in the sulcus depending upon the how is your back condition. So these are the different rings available in the market, Alcon ring, Sioni ring. So I will not be talking indications. Once again, all lens subluxation, pseudo exfoliation, high myopia, Marfan syndrome. There are three types, three sizes available: 10 mm, 11 mm, 12 mm, depending upon the axial length of the patient side. So key points to success of CTR is use a high viscosity viscoelastic. Making the incision is very important. Low flow rate, low vacuum, and low bottle height to perform the slow motion phacoemulsification. I will not be talking much about the Siani ring. Once again, indications are same, but these are rings, actually Siani rings designed for the scleral fixation with the sutures. So these are other segment devices in the surgery, that is Ahmad capsular tension ring. These are helpful in once again fixing the back to the sclera. So in conclusion, this is one of the case I did the last time. Patients with the albinism with a subluxated lens, you can see, keep your mind cool. Dilate the, open the pupil with the retractor. Do the Rexis. See, while doing the Rexis, I found out there is subluxation. So need not have to become panic. Now I am putting even capsule hook also. Try to stabilize the bag. Then you go ahead with the phaco. I think you come out with it very easily. In summary, creating the Rexis carefully, placement of hooks and retractor carefully, avoiding intracapsular procedure that can place stress on the zonules. IOL implantation should be done carefully without existing pressure on the zonules. Once again,